protocols that we've come out with as to how we approach our patients is a three-step approach. First, assess the infection status. Secondly, clarify the indication for echo. And then thirdly, deliver the appropriate level of imaging. And I'll clarify each section as we go along. So step one. So the first is to risk stratify the patient. And we've used a traffic light system, so red, amber, green, but essentially risk stratify the patients into those that are category 1, so confirmed COVID, or category 2, suspected COVID, and those patients require full PPE. And I've written down what we feel is the right level of PPE in this setting, given the backdrop of our view on what an echo procedure entails. So category 3 are the COVID negative patients, and really this is all put in the backdrop of the patient presentation, their bloods, their serology, and also their imaging. Now, the patient in category 3, there's an extra bit of protection I think we need to build in here, because we can't test every patient, and you can't also test all your staff. So we have a questionnaire to really help us understand whether we think there is a real risk that this patient could be a carrier. Have they been exposed in the recent couple of weeks? So we'll ask specific questions like, does the patient have a cough, a fever, or have they been in contact with anyone with those symptoms, or indeed COVID positive in the last 2 weeks? We'll also ask if there's been travel in the last 2 weeks, although less of an issue now because we're almost in near lockdown. So once we've established the risk and we've categorized the patient 1, 2, or 3, the second step is then to clarify the indicator for the echo. Now, our bar for performing echo has changed in this setting, given that this is a highly contagious disease. So we really have to be clear that if we do scan the patient, that we're likely to make an immediate change in management. And really thinking about that broadly, I've listed the type of scenarios that we may be coming across. But generally speaking, in terms of the echo, we're assessing ventricular function, in particular left ventricle wall motion abnormalities. We're thinking about any other acute pathology. So there may be a pericardial effusion, there may be tamponade, particularly if the patient's clinical setting or sudden deterioration is at a step with their pulmonary picture. Other pathologies, such as acute right heart pathology, such as PE or aortic dissection. So they're the kind of things we're looking to specifically focus and clarify, and they would be the reasons that if we found something positive like that, it would change and inform further management. And then step 3 would be then delivering the imaging, and really that's built around the personnel, it's built around the location, and then also the devices that we'll use to image with. And I've listed them here, but I'm just going to highlight a few steps. So time is short, but what I thought was, because this is being recorded, you'll have these slides and you can read the detail of this at your leisure. But what I've set out here in this slide and the next slide is really our inpatient approach to our response to this COVID outbreak and our outpatient approach. So the first one is inpatient, and I'll just focus on TOE. We've talked about aerosol generating procedures being the highest risk in terms of infection risk. So remember that it's an oral intubation. We are the patient's coughing, gagging, and we're suctioning. So we have to ensure there's a good reason to do the investigation. And so the first question is, are there other alternatives that we can use? Is there previous imaging on the patient? Do we have any transthoracics that have done recently? Is perhaps another alternative imaging modality possible, like CT for LA appendage thrombus? If we then do the TOE, the key highlights here really are to say that we would use full PPE for all the staff, and then of course cleaning should be using the high disinfectant products, and we use Tristal wipes. These are chlorine-based products which are adequate in this setting. In terms of transthoracic echo for our category 1 and 2 patients, the issue here is movement, and we don't want to move infected patients to different areas. So we will go to the ward. The focus is around using easily portable devices, so these handheld ultrasound devices. We limit the scan to focus on the clinical question. So we will plan our scan, we'll take limited images, but make sure that it's still comprehensive and we don't need to go back. We won't measure at the time, we won't use ECG. And then the other key setting, other than the PPE that's already been discussed, and we've already said that in this setting we'd use full PPE, the issues around cleaning, but also wireless upload. So we've set up all our machines to be able to upload wirelessly all our images so that we can quickly review and report rapidly so that it's useful to the clinicians. And then category 3, those patients that are clean, they can go to our clean echo lab, which we're keeping clean throughout. And the issue that I would highlight here is this concept of segregating inpatient and outpatient scans within the lab, so you clearly keep everything as clean and as green as possible. Then the last slide, really, the highlight that I wanted to put out here are two things. First of all, triaging when it comes to your transthoracic echoes. I've already discussed TOE, so I'll leave that to one side. But on the right of the slide, the triaging, the key thing here is we've looked at patients who definitely need a scan where we feel this will make an important clinical change at this time point. So everything else can be postponed essentially. So we've kept those on a list, and we'll rebook those when it's necessary. But for those clinically urgent patients, it's interesting because for our service we're doing about 20,000 echoes across 3 sites and also community. Our patients that are typically the urgent ones are the oncology and those that are having urgent life-saving surgery. But all the rest can be postponed. Then the other key thing to think about on the outpatient setting is where you do these scans. Now, you want to do it in a green area, so only category 3 patients will come to the echo lab or to another site. But what we've tried to do is, rather than bringing them to a hospital site, we've moved them all to a coal site. So we're lucky enough to have community sites, and we're using those as our green sites for our category 3 urgent outpatients. So I hope that this has given you a very brief but quick overview of essentially how we are approaching this issue. And so I'll come back to the summary and the principles of our steps of assessing the patient status, clarifying indications, and then delivering appropriate